folks from Kirksville. We're delighted today to have Dr. Hahn and Dr. Danto talking about OMM and pregnancy. So I'll turn it over to Dr. Hahn.
All right. Hello, everybody. For those of you that don't know me, my name's Greg Hahn. I'm one of the NMM residents here. I'm a OGME too. This is going to be the first of a two-part lecture series done with myself and Dr. Danto on OMM and pregnancy, as well as acupuncture and pregnancy. So I do have one disclosure to make for those of you who know me. You all know that I have, some personal beliefs as far as children go, and kind of have come to believe that they're the worst possible consequence of sex. But so please forgive my attempts at humor. There's some, pictures in here. I don't mean to offend anybody, but well, hopefully you can forgive me. My opinions are not those of Dr. Danto or Northeast Regional Medical Center or KCOM or the OMM department or anything. So without further ado, so just a little summary of the presentation. We're going to start off with general reasons that we get patients for referral to the OMM department. Talk a little bit about epidemiology as far as some of the complaints that women come in with in pregnancy. We'll talk about and review some of the musculoskeletal changes that occur during pregnancy. Talk about it from an osteopathic perspective, the considerations that we have when we see patients. There will be some selected OMT techniques, which I'll mention just briefly as far as what we're going to do on Wednesday, but I'm not going to get into them too much today. Talk about some specific treatment considerations for the pregnant patient. Then we'll talk, depending on how much time we have left, on evidence for exercise and exercise recommendations, and if we can, go through some stretches and exercises and self-treatments. And then I'll hopefully turn it over with at least half the time to Dr. Danto. So, common reasons that we get patients referred to us from in the OMM department. Pain syndromes mostly, back pain, neck pain, hip and pelvis pain. We get patients that come in with headaches, peripheral neuropathies, mostly carpal tunnel syndrome and sciatica. And those are kind of the reasons that patients are sent to us. However, as osteopathic physicians, we're not just dealing with pain. We're dealing with all sorts of somatic dysfunction. So we're dealing with lymphatics, autonomics, and a whole plethora of issues as far as the patient's health is concerned, all of which can, hopefully culminate in relieving their back pain or pelvic pain. So a little bit of epidemiology. 1 to 2/3 of all pregnant women will experience back pain at some point during their pregnancy. So in this case, the lady on the left is doing pretty well. One in the middle maybe hurts a little bit, and the one on the right doesn't look super happy. 41% of women say that their first occurrence of back pain happens during pregnancy. It's most common during the second half of pregnancy, but I'd go even further to say, most of my patients that I've seen in the clinic are coming in around their 30th week, even into, 36th week. It's pretty rare that I get anything before 26 or so. Would you all agree? Like 20th week is pretty rare, and only every now and then do I see anybody in the first half of pregnancy. This is another interesting statistic that teen pregnancy drops off after age 25. I thought that was funny. So what causes pain? Generally, in the vast majority of patients, it's going to be mechanical musculoskeletal issues. There's lots of muscle weakness, ligamentous laxity, which then leads to altered posture and muscle imbalance, which will predispose women to having scoliotic curves, spondylolisthesis, things like that. There's obviously a good amount of weight gain with pregnancy, and all that together puts a lot of strain on the lumbar spine, the pelvis, and going up into the thoracic spine and the cervical spine as well. That being said, there are non-mechanical causes of back pain, and and I'm not going to talk about them too much, but just as I mentioned, you don't want to miss anything. We're doctors, not just manipulators. So talking a little bit about risk factors. So they're pretty much what you'd expect, and a lot of them are risk factors for just back pain in general that aren't necessarily unique to pregnancy. People who have had back pain before, previously, people who have had back pain when they've been pregnant before, you know, I don't know, it's not much of a leap to me to imagine that if you had back pain during your first pregnancy and your second, third, fourth, fifth pregnancy, you'd also have some pain. Young and advanced maternal age, my personal experience is a little bit more with advanced maternal age. I don't see a ton of, you know, 20-year-olds coming in, although, you know, it is somewhat common. Multiparity, there's a pretty strong correlation with back pain in general and emotional stress, and even more than that, psychological illness and issues as well. Obesity, again, the weight gain is a big part of the stress and strain across the lumbar spine and pelvis, and then demanding work and low socioeconomic status, low educational status, that sort of thing. So talking a little bit about the weight gain, on average it's something like 25 to 35 pounds. It depends a little bit on how much you weighed before that as far as recommendations go. That weight is distributed a little bit. You know, baby, depending on where you're at in pregnancy, will weigh, you know, various amounts of weight as it's growing and developing. But there's a certain percentage of that associated with baby, and then the structures that are supporting and nourishing baby, and then there's some more that are supporting and nourishing mom in addition to supporting and nourishing baby. Recall there's a bunch of hormonal changes associated with pregnancy. The release of relaxin, in addition to progesterone, and to a lesser extent estradiol, all lead to some smooth muscle relaxation and some ligamentous relaxation and laxity as well. All of that is so that this can happen, so that you can, you know, push out an 8-pound baby through a not that big orifice. And so you end up, because of this smooth muscle relaxation, ligamentous laxity, with postural changes leading to, you know, pathology like that diastasis recti and that sort of thing as well. Talking a little bit more about the muscle imbalance, if you take a look at the posture, you know, again, a lot of it's pretty straightforward. You end up with increased spinal curvature, so increase in your lumbar lordosis, increase in your thoracic kyphosis. You end up with this anterior head carriage, which puts a large amount of strain on your upper thoracic spine, as well as leading to shortened, weakened anterior cervical musculature. With this lordotic curve, you end up with elongated, dysfunctional, even more than stretched out psoas muscles and hip flexors, as well as weakness in the glutei muscles as well. So again, just another slide about those postural changes. You can, again, in this diagram, a little bit better see the changes in those spinal curvatures. You can see that anterior tilt of the pelvis. Because of her shoulder position, you don't really see it quite as well, but those shoulders do tend to come forward even as the thoracic spine is arching out posteriorly, which again puts a lot of strain on the upper thoracic spine and the upper chest as well. You get this overall shift of weight forward, as well as a widening of stance to sort of support all of this weight and postural change that comes with pregnancy. Another slide sort of devoted to this. The main purpose of this is, one, to sort of correlate those postural changes with the pathology that they'll come in with, the complaints as far as my neck hurts, my back hurts, I'm having numbness and tingling, I'm having lymphatic congestion. But also to keep in mind that a lot of these changes after women are done being pregnant will sort of stick with them. Those loose, weak muscles, if not addressed, can stay loose and weak. The tight, angry muscles can also stay tight if not properly addressed. So don't fret though, there's OMM and we can treat you. So osteopathic considerations. So, you know, to a certain extent, we're dealing with the somatic dysfunction as a way to access your pain, a way to treat your pain and relieve your pain. So we're paying attention again to the different aspects of somatic dysfunction, all the aspects of musculoskeletal, arthroidal, myofascial, neurologic, lymphatic, vascular. We're dealing with posture and mechanics. We don't generally get a lot of laboratory testing. It's not usually indicated, and it doesn't usually change your treatment course, at least from our perspective. Keeping in mind also that the vast majority of back pain resolves postpartum, and that if you can just sort of get them through the last few weeks of pregnancy, hopefully this will all resolve once they are done being pregnant. And so going towards those osteopathic considerations, obviously you want to address autonomics, and so autonomics for the uterus and the placenta, sympathetics are in the T11 to L1 region, parasympathetics in the S2 to S4 region. You do end up with a good amount of lymphatic obstruction, and this is due in part to the mass effect of the uterus and baby on lymphatic structures as far as the inferior vena cava and that sort of thing. But it's also associated with fascial tension, again, from those postural changes. You can imagine if you've got those muscles that are elongated and weak and other muscles that are tight, that would cause strain across lymphatic structures and then lead to fluid retention in peripheral extremities. And then there's just that statistic of quite significant portion of women, up to 80% or so, have swelling in their feet and legs, and to a lesser extent in their arms as well, but they do get it in their upper extremities also. So as far as what sorts of techniques do we use in OMM to address these, pretty much the techniques that you'd use in anybody. There's not really necessarily a contraindication. The ligamentous laxity secondary to the hormonal changes does change how you will approach your patient. So you might choose different techniques, but I'll still do HVLA in my pregnant ladies, still do lots of soft tissue and counter strain and direct, indirect. It all sort of depends on the dysfunction. But so I apologize for this slide being a little bit busy. The main thing I wanted to present in this is that there was a study in 2012 in the JAOA, a review article that reviewed several articles that essentially show that OMM can help with pain and symptoms during pregnancy. They did mention a lack of randomized controlled trials, which, well, that's a little bit sad, but you know, anecdotally at least, we do get a lot of good results treating pregnant women. Our OBs in town keep referring them to us, so I guess we must be doing something right. Although there is, as in all of osteopathic literature, a lack of, you know, of good studies as far as randomized control trials, placebo-controlled trials. So a few treatment pearls, at least in my practice, probably the biggest thing is just considering positioning. A lot of pregnant women won't tolerate being in a prone position as baby develops, and also as baby develops they won't necessarily really tolerate a supine position very well because of that pressure of the fetus on the inferior vena cava. They'll get cold, clammy, nauseous, like just not feeling very comfortable, and you have to turn them on their side or sit them up or something like that. A lot of women don't like sitting because of coccydynia, or a pain in their pelvis, hurts when they sit, so you have to find a semi-reclined position and things. So the treatment position that your patient tolerates is going to be a big part of how do you go about treating your patient. I give my pregnant ladies a lot of homework because they do have that smooth muscle and skeletal muscle relaxation, as well as the ligamentous laxity. They come in dysfunctional, but they're prone to dysfunction a lot. So the more self-treatment techniques, the more stretches and exercises I can give them as far as prevention of dysfunction, the better. A lot of times I'll talk to my pregnant ladies about proper lifting technique, proper technique for getting up from sitting or a lying down position to get up to a standing position without straining their lumbar muscles as well, which I'm not going to get into too much today, mostly because of time. And then one last thing, I do pretty much always recommend to the pregnant women that I treat that they do, even after they're done being pregnant, although most of that musculoskeletal pain does resolve after you're done being pregnant, I do encourage them to come in at least once for a postpartum treatment just to make sure all those postural elements are kind of addressed so that they don't kind of settle down crooked, if that makes sense. And so just really briefly, the techniques that I use a lot, and talking with Dr. Danto, what we'd like to cover as far as manipulation goes is there's really good techniques, still techniques for the pelvis and sacrum are not something that we really get exposed to a lot at Kirksville. There's a lateral recumbent articulatory technique for the pelvis. Supine muscle energy and still technique is great for the sacrum, again, because of those the restrictions as far as treatment position goes. And then there's a seated traction HVLA technique, which I use a lot since the patients don't really tolerate that supine position very well either. And so we'll be going through these on Wednesday at the 7 a.m. lecture. So I'd really like to encourage people. Dana's not here today, and neither is AJ, I guess. But you know, if you yourself are pregnant, if you've got a wife that's pregnant, a girlfriend that's pregnant, anybody else practically that's pregnant that wants to come in and be treated and be made example of, so to speak, we'd encourage you all to bring people with you to that session. So talking just a little bit about contraindications to OMT, and really most of these are relative contraindications. You'll notice a lot of these are sort of obstetrical emergencies, and you know, it is true that if a woman is having premature rupture of her membranes, that in that moment that she is rupturing, you don't necessarily want to be doing a lot of especially vigorous OMT. That being said, that's not to say that you can't treat her later on, or you know, that it was not indicated previously. So again, a lot of these are relative contraindications, and there's totally a place and time for OMT, both before they give birth, during labor, and then after labor as well. This is just a good pie chart for so, and again, I'm going to have to apologize about the next couple slides. They're a little busy. I didn't get this information until last night. But essentially, again, what I want to draw your attention to is just that first line. The Dynamed is Dr. Danto, it's a website for evidence-based medicine that the hospital has access to. So I didn't know about it until last night. So this is from that website. It reviews a whole bunch of evidence and then kind of assigns it categories as far as level 1, level 2, level 3 evidence. The benefits for exercise in pregnancy is essentially at a level 2, and I'm not going to go into the individual studies that specifically, and I apologize for not having more pictures, Dr. Danto, but essentially the evidence is fairly favorable in terms of exercise being a good idea for pregnant ladies. Now that wasn't always the case. More historically, there was a movement at one time to have your pregnant women avoid exercise and kind of be on bed rest and that sort of thing. And that didn't necessarily have really great outcomes. So that's a little bit of a paradigm shift. Talking about the potential risks of exercise in pregnancy, again, level 2 evidence saying that it's fairly safe. They do talk about some chance of risk to the mother in terms of prolonged labor, but there's really not a lot of evidence showing that it has any effect on maternal weight gain, baby's birth weight, length of gestation, and that sort of thing. And another thing that was interesting to me, and I would have thought differently, is that it has not really been, exercise hasn't been shown to affect the rate of gestational diabetes, which I would have not thought that. Going on to what the Dynamed site recommends as far as exercise goes, they suggest that you essentially tailor your exercise regimen that you recommend to your pregnant ladies based on how active they were before they, really became pregnant. So they talk about a certain percentages of the maximum heart rate, which is calculated based on your age, and then also duration and frequency of exercise, depending on whether you were pretty sedentary before you got pregnant or whether you were a marathon runner or otherwise an elite athlete before you were pregnant. Obviously, if you were capable of more ahead of time, you were probably capable of more during pregnancy. They suggest a talk test that if you're exercising, say you're walking around a track with someone, that you should be able to carry on a conversation, and if you're not able to carry on a conversation, reduce the intensity of your exercise. I don't know if I personally necessarily agree with that. I would say maybe like 4-word, 5-word dyspneic. I get out of breath going up a flight of stairs. So maybe I'm just super deconditioned, but my heart rate doesn't go up a lot before I start huffing and puffing. But anyways, they do mention certain exercises to avoid in pregnancy, and it's pretty much common sense. You don't want to have your pregnant lady going into a competitive boxing match or competing in powerlifting or something like that. So they're all fairly straightforward. They talk again about contraindications to exercise. It's a little more a complete list. Again, it's mostly obstetrical emergencies, medical emergencies, as well as far as if they're hemodynamically unstable, you don't necessarily want them walking a track right at that moment. But again, in my mind, these are mostly relative contraindications in the sense that if in moments where they're not way out of control or hemodynamically unstable or something like that, I don't super see a reason to have them avoid exercise. So, talking a little bit about stretches and exercise that I personally like to give pregnant ladies. Again, you're going to tailor your exercise regimen as far as exercise or stretch prescription based on what they're coming in with and what their somatic dysfunction is like. So, this is just a quick list, but using the Psoas Stretches as an example, if you scroll back up to earlier in the presentation, because of that increase in the lumbar lordosis, generally speaking, in terms of posture, your psoas actually gets kind of stretched out and weak. That doesn't mean that it's not dysfunctional, though, and it doesn't mean that they don't develop spasms in their psoas. So it doesn't mean that even though it is in an elongated position that you don't recommend stretches for the psoas, and actually that's something that happens a lot, and you can kind of attribute a lot of their dysfunction or a lot of their symptoms to psoas dysfunction is pretty darn common. We're kind of running out of time, and I would like to give Dr. Danto a good bit of time for his presentation, so I was going to ask for volunteers, but I think I'm going to just kind of chug through and more describe what the types of stretches I do. So this is called the CAT, or the camelback stretch. Essentially what you're doing, it's one, I kind of think of it as a self-articulatory technique in your lumbar spine. Essentially what you're doing is you're getting down on your hands and knees and arching your back as far up as you can and pooching out your belly as far down as you can. What I tell people is that when you're doing the arch, that especially if there's like a certain segment that is really quite sore, to imagine, and you can even do it like placing a penny on your back or something like that, and imagine pushing that penny up as far as you can, really feeling the stretch across the back side of your back. And as you come into this, the more increasing your lordosis, I talk to them about stretching the front side of your back. Going into the next exercise, this is fairly related to the pelvic rock or the pelvic clock or whatever you want to call it, which becomes a little bit more of an exercise in terms of retraining abdominal musculature, tightening up weak glutei, and stabilizing your pelvis. Again, you can kind of use it in the sense of a rock going back and forth from a 6 o'clock to a 12 o'clock position, which is usually where I'll start out, with women, depending on how deconditioned they are, how much they need their abdominal musculature retrained, so to speak, or woken up. And so what I'll say is start off just going back and forth from 6 to 12. flexing, holding it for 10, 15, 20 seconds, something like that, and then reversing, flattening out your spine the other way. As they get better at that, I'll tell them to start adding the 9 o'clock and the 3 o'clock position as well, to sort of rotate back and forth, to start involving like abdominal obliques and that sort of thing. As they get better and better at it, I'll tell them actually go around the clock. So go from 12 to 1 to 2 to 3 and sort of around the whole clock. Again, the idea being that that exercise will help stabilize your pelvis. And so talking a little bit more specifically about abdominal retraining and pearls as far as the pregnant patient, crunches are fine to do and actually really good to do, but again, sometimes your patient won't tolerate that supine flat position, so you might have to alter things a little bit, modify the exercise. One thing you can do is have them brace up a little bit against some pillows, or if they have like a wedge like they have in physical therapy or something like that, that's something you can do to sort of help change the vector that gravity has on the fetus, so it's not compressing that inferior cava quite as much. You can also have them roll over onto their side, and the lateral recumbent position is a lot better tolerated, and that's great for training the abdominal obliques and that sort of thing. Planks are great and generally pretty well tolerated. There's all sorts of different plank positions, whether you're in full plank or half plank or side plank, or a modified plank where you're having them go on your knees. Just wanted to point out something in terms of posture. So if you look at like this lady, she's doing a pretty good job. She's keeping her shoulders tucked in at her side. A lot of women, when you get them into that plank, if they're deconditioned, especially across their shoulders, their scapulas will kind of wing up a lot because they're not, their serratus anterior has lost some of its tone. So telling your women to sort of keep your back nice and straight and tuck in their shoulders and kind of push forward by tightening up their serratus anterior, which is kind of hard for a lot of people to localize. And then also, this lady's got her butt way up in the air, so she's maintaining kind of a flexion through that pelvis. So it's a much better exercise to sort of get them to straighten out their back and have a fairly level plank, so to speak. Talking a little bit about psoas stretches, again, despite it being kind of a lengthened, stretched out muscle in terms of the posture, it does tend to cause a lot of pain. You do find a lot of dysfunction in it. So psoas stretches is something I do give a lot. In this case, I'll tell them to do it fairly specifically in terms of whether I get them to involve their rectus femoris or whether I get them to concentrate more on their psoas. But again, positioning is a big deal to some ladies. So some pregnant women won't tolerate being on one knee for very long. So you might have them lie or be in sort of it's kind of, I guess, an upward dog type position to a certain extent. And you can do that with one leg back. You can do it with both legs back. And you can also do it standing. It doesn't involve the rectus femoris quite as much, but it's still pretty good for the hip flexors, depending on how tight they are. Then talking a little bit about self-mobilization techniques. These are things that generally I'll tell them to do it. Not everybody has a foam roller super commonly, but I'll a lot of times recommend that they just roll up a towel, and really all you need is a fulcrum to kind of extend over. So in this case, you're mostly treating that thoracic spine. You can treat into that thoracic kyphosis. Essentially what you do is, if they have two segments that in between there is fairly stiff, you have them lie the lower segment across that foam roller or across the towel, and then just kind of extend their back over that and let their back kind of settle down. It's really good for treating flexed segments. So if I'm finding lots of extended segments, which is not super common, I probably won't give them this technique to do. But again, flex segments I find to be way more common because of that increase in the thoracic kyphosis. Another one that I'll do, if they wouldn't like to be lying down on the ground, is to give them one where you kind of extend over a chair. The same idea. I usually use the one more with the older lady, but she's probably a little old to be pregnant. Anyways, but that's the whole advanced maternal age, right? Could be a risk factor. So I'll have them come into a chair. we'll use this one, something with a fairly firm back, maybe not something quite this hard as far as the wood goes, but you know, if they're hurting kind of right up here in their back, I'll have them come down to a certain, to just below that spot, bring their arms up above their head, extend their back over, kind of relax there, and then add to that a little bit of a treatment for their shoulders, have them open up their shoulders, open up their, get a good stretch in their pectoralis muscles, and then also squeeze a little bit with those weakened rhomboids, middle trapezius. It's actually really good, and I just cracked my back, so real good for self-treatment. Ooh, I dropped the mic, sorry. Going on to another type of self-mobilization. In this case, again, I don't have them. You can use a pillow, that's fine, but you know, even just, again, rolling up a towel or something like that, you have them lay it instead of horizontally across their spine, parallel, just along their spine, and then you can have them kind of open up their arms and and this is mostly treating that anterior shoulder posture, getting them to open up their upper thoracics and upper ribs. Another real good self-mobilization technique for rib dysfunction. She's using 2 balls. I usually just tell people to use 1, but either a tennis ball or a racquetball, something fairly soft. Tennis ball is going to be a little bit bigger. Racquetball will be a little bit smaller, depending on what you can tolerate. And you essentially, if they've got like if they've got pain more out along like a rib angle or a rib head or something like that, you can lie a tennis ball down and then just kind of, you know, roll onto it and kind of get that rib to sort of gap up off of its articulation with the thoracic spine, and a lot of times that'll help with chronic rib dysfunction. But again, I don't usually have them do 2 at a time. So those are my references, and that's pretty much it for me. So I'm going to turn it over to Dr. Danto, and we'll keep going in a little bit. I'll get your PowerPoint.
Thanks. All right, so there's Cape Girardeau. Are you guys there? Cape Girardeau?
Their eyebrows went up.
Their eyebrows went up? Is that you guys at Cape Girardeau right there? Did I say, is that them? Okay, and there's Springfield, right? Is there,
We get Springfield on there.
I think they're on there. Springfield, can you unmute and talk?
is Springfield there anymore? What's the other one? Is there one more too?
St. Joe.
St. Joe's, are you guys there?
Yeah, just unmute and talk if you are there.
Say hi.
Can you guys hear me? Can you say hi?
There we go.
Hi, I'm Dr. Danto. Hi, everybody. This is my first time lecturing here at Northeast Regional Medical Center and on the airwaves. It's nice to be on the air. I actually came from, I'm the newest member of the OMM department here at ATSU. Formerly I was at Comp, and we were kind of a distant, we did a lot of distant lecturing with Comp and Comp Northwest. So, you know, I do have a question. Number one, I'm going to be talking a little bit about Chinese medicine and acupuncture. How many people have how many people have had acupuncture done on them? How many people are somewhat familiar with acupuncture? Okay, feel like you're comfortable with it? How about at our distant sites? Is there anyone in Cape Girardeau? How many of you guys have had acupuncture? All right, this is Springfield right now. St. Joe? St. Joe, how many of you guys have had acupuncture? Any of you? You can raise your hand. I can see you. None of you? Okay, so that's okay. All right, so I'm going to be talking a little bit about this, and I'm going to use this. All right, so I'm also going to be talking a little bit about osteopathy. I've been a physician for almost 20 years now, and more than half of that I've been practicing with acupuncture along with manipulation and all my skills. It's really brought a different type of appreciation to the whole body system, because it's another way of looking at the body. So TCM view on preconceptual care, they look at it just as importantly as we look at it in traditional Chinese medicine. Worry will inhibit qi from flowing. Anger gives rise to liver qi stagnation. Fear will cause qi to sink, which may result in miscarriage. And joy may lead to irregular menstruation. many traditional Chinese people who do acupuncture like to start treating their patients both with acupuncture and nutritionally and philosophically about 3 months before they're ready to conceive. You know, it's very much like osteopathic medicine that we're thinking about things in preventive medicine type of way. As a matter of fact, I did look on Dynamed, and I was just looking to see some of the things, if there is evidence to back up some of what we see in the textbooks. And depression, stress, and anxiety are associated with increased risk of preterm birth and C-section. And this level of evidence is at the level of 2, so that pretty much goes along with the previous slide I was talking about. Back or pelvic pain may be reduced with acupuncture. The level of evidence there is 2. Dynamed reviewed the osteopathic manipulation, and it was not as favorable as acupuncture, which I don't think they had that latest study that was more of a meta-analysis that Greg presented. Nausea and vomiting is treatable with acupuncture and or E-stim, or acupressure and E-stim, but it's not as effectively treated with acupuncture. And then breach correction is moxibustion. Moxibustion is like lighting a needle on fire or lighting an herb on fire to effectively, it can warm up the needles, it can warm up people's skin. I don't like this putting on the skin, I like putting on the needles, and that can also affect, well, as I said, breach correction. So what's qi? You know, because I talked about qi earlier, the Chinese look at qi as the fundamental animating vitality of life. And qi runs in different channels. Here's a picture of all the principal meridians. There's other meridians that they call curious meridians or wandering meridians, and they seem to shoot from principal meridian and off these different principal meridians. The principal meridians are named for different organs. A lot of the organs are, what that means is that there's a lot of points in that particular channel, and even part of that channel that goes directly to the organ. But having said that, there's points on every organ and every channel that goes to all the different organs, but there's just more points on the ones that are named after that particular organ. So I often make the analogy with my patients, and when I'm introducing the concepts of acupuncture, is that acupuncture channels are like subways that run through the body, and the acupuncture points are actually like subway stops where we can put needles in to adjust that flow of acupuncture. This is a 7th century rendering of the bladder channel and fetal relationship. The bladder channel starts like on the outside of the toe and runs up the body and covers the entire spine, hence the spinous processes that you see. But those lines coming off of the channel actually have to do with a relationship that the energy going to the fetus is fed by that kidney bladder channel. Acupuncture channels are kind of like rivers running through our bodies, and a lot of rivers have rocks in them. Okay, and I look at the flow can be disturbed by these rocks. Is what we conceptually think of it. We want smooth flow through the body. The rocks are really more, I think, of what we treat with osteopathic manipulation, the structural problems. You can treat people's bodies with, structurally with manipulation. You can treat them energetically with manipulation. But most often we associate acupuncture more with an energetic change. It's a lot easier to change something structurally than it is sometimes to change something structurally and affect an energetic change than it is to change something energetically and get a structural change. But you can do both. And this is a picture of Dr. Mike Couture doing some HVLA. And I liken it to taking something and basically just breaking apart those rocks. And one of those wrecking balls breaks apart those disruptors to the proper flow of qi in our body. And here we have some acupuncture needles going in. And you can see I mean, you know, it's kind of funny because people go to my office and say, Dr. Danto, I go home after your treatments and I go and I lay in, you know, I'll go lay down and I'll put on some soft music and I'll, you know, turn the lights down low, and I just can't relax at home as easy as I can in your office. It might actually be the needles, is what I tell them. You know, the needles, you know, it's like forced relaxation for people. They can't move around. They can't like get up and run someplace. If you get up and you have a needle in you, it's a little bit uncomfortable. And of course, I said before that you can affect an energetic change. I look at the flow of the primary respiratory mechanism being very similar to the flow of qi through our body, and certainly, which I'm kind of getting ahead of myself, but I like to get ahead of myself. I'll repeat myself because that way people will pay attention. But the flow of the extracellular fluid, it flows through the body, and that's part of what we're feeling with the primary respiratory mechanism, and that's the same channels in which the qi flows. So how do you choose manipulation versus acupuncture? It helps to have some experience in this before you make a decision. There's a lot of different things I look at. One of the things I look at is the pulses. Okay, and in this screen near the bottom, you'll see that there's numbers on the wrist, and I'm going to invite you to take your wrist and take your hand and check your own pulses, and put your index finger. You're going to be proximal and distal, feeling the radial pulse, proximal and distal to the radial head, and then your middle finger is going to be one proximal to the middle finger is going to be closer to your body. And you're going to feel, and what I want you to do is to tune into your most distal pulse and kind of feel it, and then compare that to the middle pulse. And then you compare the middle pulse to the most proximal one. And with some of you, you might find that it's not entirely even. Okay, and I was introduced to pulse diagnosis. My interest in acupuncture, I learned about it as a medical student. And so I was checking everybody's pulses this way because I was like, so there's places that you can feel the radial pulse greater than other places, and you know, it was fascinating. So I've always been checking it. I didn't always know what I was feeling. But what you're really feeling is, if you're feeling the right wrist, the superficial pulse is going to be related to the right wrist is actually lungs, large intestine, stomach and spleen, and then the triple heaters and the circulation sacs. And those are the meridians that are on the front and the back of the body that are not necessarily associated with an organ, but they're kind of just right down our midline. And then the left side is going to be the small intestine, heart, gallbladder, liver, and then the kidney, bladder, which I told you runs up the back of the body and is often associated with back pain. And so if I find that somebody's history matches like where the pulses are, where the channels are in somebody's body, and their pulses reflect something that matches the history, that matches where the problem is, then I sit there and I'll lean towards doing acupuncture on that patient. But very often I'll do manipulation first because, as I said, it's a lot easier to make a musculoskeletal change that affects the energetic than it is to make an energetic change to affect the musculoskeletal. This is a fancy chart, and it's the channels that you want to avoid energetically in maturing organs in a fetus. Okay, so you're treating a mom, but there's organs that are related to it that you don't necessarily want to affect. So during the first 1 to 4 weeks, I wouldn't treat the liver channel on a mother. Okay, during the next 4 to 8 weeks, I wouldn't treat the bladder channel. 8 to 12 weeks, pericardium. So there's relative contraindications. It's a relative contraindication if, and there's things to consider when you're treating a patient. The yin and the yang, these are Chinese concepts, and yang is associated with dynamic, the sun, summer, hot and dry, fire, superficial, dispersed, and left. Yin is static, the moon, winter, cold and wet, interior, concentrated, and right. And so often when they talk about conception, it's yang of the sperm meeting the yin of the ovary. And so they have, even in Chinese medicine, they talk about the ideal time is when the yin and the yang is in balance, is to conceive, and they say 4 a.m. Okay, now having said that, you and I both know medically that when you have sex, it doesn't mean that you're going to get pregnant at 4 a.m. It's like, you know, it's kind of as the sperm make their way through the uterus and the fallopian tubes, eventually they get to an ovary. So it's like you can't really control that precisely, but it's just a little bit of where the Chinese are coming from. Yin they talk about as being the feminine passive principle in nature that in Chinese cosmology is exhibited in darkness, cold, and wetness, and that combines with the yang to produce all that comes to be. And yang is the opposite. I used to pronounce it yang, but they pronounce it yang in Chinese medicine. So qi, there's like over 20 different types of qi, but there's 3 main types: wei qi, rong qi, and yuan qi. And the wei qi is often used in something if it's an acute problem. They use it a lot in emergency medicine. The acupuncture course I took, 80% of the ER doctors, they just are there to learn the wei qi treatments because they know they can make immediate effects in their patients because it's usually emergent. It's usually an invasion into that defensive energy. So, and the nice thing for them is it's not quite as many needles that you have to do as if you're doing a principal meridian treatment. Rong qi is assimilated vitality from nourishment and food, what we eat and what we ingest in our and then it circulates with the blood. And then yuan qi is inherited by genetics. You know, if you're, and it's even affected, the yuan qi is even affected by what's going on with your parents when they conceive. When my parents had my big brother, he was, you know, they were young. They were in their 20s. When they had me, it was 15 years later. My dad was working 12-hour days minimally. And, you know, now I've always wondered why, previous to this, why my brother had more energy than me. From a Chinese perspective, this is the explanation. Maybe I'm just lazier, I don't know, but who knows. This is a picture of a back, obviously, a picture of the muscles. And what I want to point out, now let's see if I can do it with this. You can't see that. Okay, what about over here? All right. So the acupuncture channels are actually on either side of the bladder channels, actually on either side of the erector spinae muscle mass. So this, so you would put needles on either side of this, and here's another, like just a cutaway view of this. If we go to the next slide, you can see that they would be putting muscles actually in here between the multifidus and the, well, usually the longissimus, and that's the theory is that the fascia is actually one of the things that transmits electricity and qi, and fascia is actually a better conductor of electricity than nerves. So it's a pretty impressive system that they're proposing. This is the ATSU KCOM Family Medicine Residency Clinic. They all have needles on their GV20 because we all let them put them in. And before I go on, I just want to say that this, what's going to happen the next Tuesday is next Wednesday that we're doing the Tuesday morning? Wednesday morning. So next Wednesday morning at 7 a.m. we're doing a lecture on demonstrating the manipulation and acupuncture, some acupuncture techniques for a pregnant patient. That's going to be recorded for the distant sites, so you guys can watch it online, and it's probably made available here as well if you ever want to like refer back to it. So GV20 is a crossing point of that meridian, that channel that goes through the middle of the body, but it also is a combination where all of the yang channels combine. So they call it the Sea of Mirror Point. It's indicated for vertigo, dizziness, coma, hemiplegia, aphasia, prolapse of the rectum, prolapse of the uterus, manic psychosis, and insomnia. And matter of fact, it's so common, they actually use it for almost any type of pathology. It's one of those points that they say is able to cure almost anything in the body. So it raises the yang to treat a lot of different things. I'm not just going to say that it does what it says on the slide, but this is also from acupuncture.com. There's acupuncture resources on the web if you want to look. This is one of them, acupuncture.com, that gives you the acupuncture points, all of them. Here is a medical student's sister who agreed, she was, in pain. She went and got treated. This is like a week before, actually 2 days before she got married. She had mid-back pain. The medical student had been trying to treat her with manipulation unsuccessfully. And one of the things I tell people is you can put an acupuncture needle into a somatic dysfunction, wait 15 minutes and it goes away. Sure enough, her pain went away after the acupuncture. And I'm not saying that, I would do, acupuncture in favor of manipulation, because I do both. And I'm sure this person had both as well, but it's something that you can do, is put needles in to tissue texture abnormalities for somatic dysfunction. Now, that ends my formal, what I wanted, the introduction. I'd be willing to answer any questions that any of the sites have or you guys have. Any questions? Well, I'll tell a quick story.
What are you going over Wednesday?
We're going to go over still technique. We're going to go over some myofascial release. We're going to go over some of the exercise techniques that Greg had talked about. And we're going to go over just kind of putting a needle into a somatic dysfunction and seeing how that affects it. I've done, so like I said, I've been doing manipulation for almost 20 years now, and I can do the most elegant treatment and sit there and say, man, I got that, I treated that patient really well, and then I'll go and check them out, and sure enough, there'll be signs of tissue texture abnormalities still there. And it's like we don't necessarily treat patients to that they have to be perfect when they leave the office, but you can put a needle in those tissue texture abnormalities and the somatic dysfunction disappears. I kind of like that. It's really nice. And in my typical practice, I do acupuncture on 25 to 75% of my patients. Yesterday, out of the patients I saw, I did manipulation on 100% of them. 75% of them got acupuncture, and it consistently knocked me off my feet as to how their bodies respond to acupuncture. It's pretty amazing. The course I attended in acupuncture was at UCLA Medical School. It's one of the basic courses in the country. It's a 300-hour course. Right now, I think it's $7,500 for those 300 hours. We're talking about potentially offering something similar here, but I don't see that as being something very soon happening. Any other questions? I'll tell you guys an example. I have two babies. I'm not like Greg. I have two babies. They're 14 and 15 now. When my wife was pregnant with our first child, I'd been treating her throughout her pregnancy. She was over, we had a family dinner over my parents' house 2 months before her delivery. So she was 7 months pregnant, and she had a slip and fall on marble, and she landed on her gluteus on hard marble, and she got bilateral superior innominate shears. The manipulation, bringing those innominate shears down, was crucial. She couldn't, she had pain for the first time she's ever had pain. During pregnancy, when the relaxing gets in there and relaxes things, that's to the benefit of delivery, but at the same time, it makes you vulnerable for certain things. Certainly, even for somebody who's exercising regularly, it could, just from doing if you're not light on your feet, you could end up with innominate shears. That's one of the reasons why I recommend to my patients to get treated at least once a month for the first 6 months, and then we adjust that depending on what their needs are for the last 3 months. I look at much of delivery as the pelvis adjusting and to being able to deliver the baby. So I think there's nothing more powerful than you can do in the delivery situation than doing manipulation. I've had patients, if somebody has back pain before they, if they have chronic back pain before they're pregnant, there's 3 things that are going to happen. There's one of 3 things that are going to happen. Either they're going to get better, either they're going to get worse, or they stay the same. And that's a third and a third and a third. Manipulation is very helpful. The acupuncture is very helpful. One of the things I can do with acupuncture is a little bit of prolotherapy, but more with just acupuncture needles, and that seems to help stabilize those ligaments at the SI joints and relieve some of the pain that they can get with abnormal sacral torsions and all that kind of stuff. And if that's all, thank you very much. You guys have a great one.